In this video, I will show you how to administer intravitreal injections. I just want to emphasize that this is just one approach, my personal preference, although there may be variations in your technique. As I describe the video, I will walk you through step by step, discussing current evidence and explaining why certain methods are chosen, as well as alternative approaches you can consider in your daily practice. Since we have anti-VEGF in intravitreal injections, the prognosis of retinal and macular diseases has drastically improved in a much more favorable way. Consequently, the number of injections has exponentially increased. For instance, in 2016, approximately 5.9 million injections were administered in the United States alone, and this number has continued to rise and is expected to increase in the coming year. The whole technique is mainly focused on preventing one of the most important complications, which is post-injection endophthalmitis. Various meta-analyses have provided different numbers. For example, in more recent studies, the incidence of post-injection endophthalmitis was 1 case per 1,700 to 1,500 injections. A more recent study found that out of 71,000 injections, only 10 cases were reported, which means approximately 1 case per 7,200 injections, which is very low. I will leave the link of these articles in the video description so you can check it out. One important point to discuss is in which area you apply your injection. I usually do it in the operating room or in a designated area. Several meta-analyses have evaluated this correlation, and it has been observed that patients who developed endophthalmitis had negative cultures when the injection was administered in the OR. Interestingly enough, applying the injection in the operating room is believed to reduce the risk of endophthalmitis not because the air is cleaner, but because more stringent measures are taken, ensuring greater care in asepsis and antisepsis for both the patient and the surgeon. Using a face mask is also important because it has been found that up to 29% to 56% of cases involve bacteria from the oropharyngeal cavity. I use adhesive sterile fills and adhesive patches such as Tegaderm to isolate the eyelashes in both the upper and lower eyelids. Now yes, I have to clarify because you probably know it. There is no evidence that using these measures reduces the risk of endophthalmitis. It has also not been shown that the use of gloves is favorable in reducing the risk of these complications. This, I believe, is more a matter of surgeons' comfort and the availability of these materials. I use it because I like to take extra care as much as I can. By this moment, the patient has already been cleaned in the periocular region with 10% povidone and also received 1 drop of 5% povidone at least 5 minutes before. And of course, at this point, anesthesia has been applied. The speculum is recommended because it helps isolate or divert the eyelashes from the puncture site, although it is often considered uncomfortable for the patient. Believe me, many patients complain more about the application of the speculum than about the injection itself. So if you want to remove it or not use it, it's okay as long as you take care of not putting the eyelashes in the puncture site. Now, to know the distance where you need to apply the injection, which is 4 mm from the sclerocorneal limbus, you can use an empty trocar handle or a soft cotton tip applicator. It is highly recommended to apply another drop of 5% povidone directly in the site where you are going to inject, and wait at least 1 to 2 minutes. It has been observed that povidone can take effect within 15 to 30 seconds. Regarding the eye quadrant where the injection is administered, several articles have evaluated where it hurts less. Some recommend applying it in the superotemporal region. Many surgeons also prefer this area for comfort and better accessibility, and because many patients feel more at ease not seeing the syringe before the injection. Personally, I prefer to do it in the inferonasal quadrant. I have noticed that patients report less pain in this region, and I also have compared this in certain situations when injecting the same patient in the supranasal or superotemporal region versus the inferior nasal region, and the latter reports less pain. I also ask the patients to look in the opposite directions where I'm going to inject, and they don't see the syringe, so they don't feel anxious before the injection. Many patients also reflexively try to close their eyelids when the injection is going to be applied, and this causes that they will move their eyes upward, causing major risk of contacting the cornea or maybe applying the injection closer to the ciliary body or the lens. That's why I don't like the upper quadrants. Now, to administer the injection, I direct the needle tip at 45 degrees angle from the horizontal plane of the crystalline lens, and then I aim the needle tip towards the center of the vitreous cavity. You can use a soft cotton tip to move the eye or hold the eye in position, and also to retract slightly the conjunctiva. Now, very important, the use of antibiotics is not recommended. Several studies advise against using antibiotics before or after the injection. I only apply another drop of 5% povidone at the injection site, and then only give lubricant drops for the next 7 to 10 days to my patients. Whether you isolate the eyelashes manually or prefer not to use a speculum, that's fine, as long as you create good isolation from the eyelid margin. Tegaderm is also a good tip if you're not going to use the speculum. The use of gloves is also optional, with no clear evidence showing a significant advantage. However, povidone iodine at 5% is crucial. Studies have demonstrated that even more diluted povidone iodine at 1% or 2% can be also highly effective and reduce ocular irritation. I recommend applying povidone iodine 5 to 10 minutes before the injection, immediately before the injection, and waiting at least 1 minute. If unable to wait a minute, wait at least 15 to 30 seconds as the evidence suggests. Post-injection, I do not use antibiotics, but only ocular lubricants, which I find sufficient, and I also apply 1 drop of 5% povidone iodine also at the end of the injection in the puncture site. As always, I hope this will be useful in your next cases. Thank you for watching.